this webinar. My name is Sultan Al-Shihri. I'm the Director of Respiratory Department in Saudi German Hospital in Jeddah. I would like to start by thanking my friends and colleagues of Saudi German Hospital who arranged and control this webinar. I would like also to thank the friends in Al Company. Al Company is one of the leading companies when it comes to ventilators. Al Company are General Electric providers in Saudi Arabia. My gratitude also to my friends in Draeger Company, who I would like to call partners, not only friends, because they've been with us since day number one. This webinar will be focusing on the technical aspects of using mechanical ventilator in the COVID-19 suspect patients or positive patients, from the preparing phase through the monitoring and cleaning and disinfecting the mechanical ventilator. Our first speaker for this webinar is Mr. Clay McCall. Mr. McCall has been a respiratory therapist for more than 35 years. He's been an RRT since 1984, and he is working now as a healthcare education specialist in General Electric Company. Thank you, Mr. McCall, for joining us. And if you can please start your presentation.
Yes, absolutely. And thank you for the wonderful introduction. Today, I'd just like to talk a little bit about COVID and ventilation. I mean, this has really been something, people say I'm been around way too long, but I don't think anyone alive has ever seen anything quite like this COVID crisis. So GE, as well as other companies, have put together guidelines for using their equipment safely, for cleaning it safely and effectively, and trying to protect the caregivers and providers that are working through this crisis. And before I go any further, I look at it like my military. I want to thank everyone for your service out there, especially if you're directly with COVID-19 patients. I mean, this is a scary time, and not just the stress of work, but the stress of trying to keep from getting an infection. And if anyone has had the infection, I hope you've gotten through it well, and any of your loved ones that have. So let me get started. Let's see. It's not. Excuse me 1 second. This is not. My screen is locked. Hold on. Let me pause this. I apologize. This worked earlier. Let me see. There we go. I think it was just sitting too long. Okay. All right. So the first thing we want to talk about is special considerations in preparing mechanical ventilators for COVID-19 patients. What do you need to do? What kind of filtering do you need to do to prepare for this known infection that is you're going to be working with this patient, to protect the patient as much as possible and to protect all the providers, and the proper cleaning after it for the COVID-19 patients. And then just a little guidelines on caring for mechanical ventilators while in use with COVID-19. There's many societies that have come up with standards for treating COVID-19 patients, kind of like an ARDSNet protocol, but really a COVID-19 protocol. So, and most of the protocols are very similar. Some have little differences, but all of it's to try to give as consistent and as quality a care to the patients. So I just want to, for those that have used GE R860s or even the older Angstrom models, I just wanted to show you something for part replacement. So most of the parts, exhalation valve diaphragm, flow sensors, different thing like that, they have a number of cleaning cycles that they're good for. And a lot of this is with sterilization. So a lot of the hot sterilization processes, it takes a special kind of plastic and they can only last a certain amount of time. So this is just a recommended cleaning cycles for all of our parts. I also want to address the inspiratory safety guard because that's something where GE is a little bit different. The inspiratory safety guard is a filter that's on the inspiratory inlet of the ventilator, and it's designed to protect the ventilator, not protect the patient, but protect the ventilator from infections getting blown back into the ventilator. Now, we all know that most ventilator flows are one way, but if something can happen to the exhalation side or maybe the exhalation valve gets stuck, then there's a relief valve that opens up on the inspiratory side so the patient can breathe two ways. If the patient's breathing two ways, and that means that their exhalation is going to go back toward the ventilator. So we make a specific filter for this. People have asked us, why can't we just put a regular filter on there? Well, most of you know that there are different efficiencies for the filters out there. And we wanted to guarantee that your ventilator will be completely safe by using a filter that is at the top of viral and bacterial efficiency. You can see the efficiency on here is...
Excuse me, Clay.
Yes.
I think your screen is just freezed on the first screen. I don't know if this is the case for everyone.
Okay, is that back?
Yeah, it's back.
Yes.
Okay, did you see the last slide? I apologize.
No. I think you better start from the beginning very quickly with the previous slides.
Okay, hold on. Now, and this is interesting. Hold on one second, because when I unlock the screen, then my screen locks. So hold on. Let me do this, try to escape and get back to, there we go. Okay, so now let me go back, share screen. And
okay,
it's back. Okay.
Yeah.
Let's see. Now it's still working. I just have to keep going or it freezes. Okay. So this is the part replacement schedule. And I discussed that, and you can just look at it. And those that have GE ventilators, this is in all the manuals, the user reference manual, the participant guide, things like that. Let me show you a picture of the inspiratory safety guard. This is on the outside, and the reason that GE has done it on the outside is because we know that ventilators that have this safety valve, and pretty much all the ventilators have this safety valve, if they open, then this filter needs to be replaced. And if it's on the inside, that usually means a trip to Biomed. GE made theirs to where it can be easily taken off, quickly replaced, and the ventilator can go back into use pretty much immediately. But you can also look at the bacterial efficiency of this, 99.999%, and the same for viral. Not all filters are created equal. The only way we could guarantee that your ventilator would be safe is if we use the GE filter on that. So, but we have come out just this past year with single patient use. And with me coming from the US, this has become very popular, and this is a big demand. I don't see it as much in this region. People will sterilize and reuse, but for a lot of workflows, people like the opportunity to have a single patient use. And especially for COVID, these have been very, very popular. And you can get the flow sensor, you can get the exhalation of valve assembly, or you can get it all together as a kit. So we just want you to know, and you can of course see it's different colored instead of being the gold color. This is a blue color to let you know it's a single patient use. But as far as the quality and accuracy, they're exactly the same as the multiple use. I also like to show you for processing all the different ways that you can process, and most of these are processed. Hold on, let's see. A lot of people, do people use Sidex in this area, or sporocidin, different things like that? And the reason I'm mentioning this is there's lots of different ways to clean. And remember, when you have the exhalation valve assembly, no gas is coming from the outside through that and back to the patient. It's all going away from the patient. So some people will even just soak it in an alcohol, and it doesn't have to be sterilized, but especially with this crisis, most people are doing complete sterilization. And as I had showed you on the other graph, you can usually get about 50 cycles out of it, which in most cases is more than a year's worth of ventilation. So just talking about the different times that it takes, Neodish, make it to a 2% solution. Denatured ethyl alcohol, a lot of places in the US will do that. Just have a small parts bin and soak them for 20 minutes and then make sure that they're rinsed dry. And even a bleach water solution, hydrogen peroxide. And then the most common and probably the most effective is a steam autoclave that will do a complete sterilization, either at a lower amount for a longer period of time or for a higher degrees for a shorter period of time, depending on what you have in your central sterile department. One other thing that I didn't mention on the drawings is people will ask, what do we need to do for filtering? So GE really doesn't have a recommendation, but from all the articles I have read for what people are doing, most people are using an efficient HMEF at the end of the patient Y to make sure that the gas is going to the patient and the gas is coming from the patient are filtered as much as possible. And then if they're using an end-tidal CO2 that's a side stream, then they can do the sample line off of that to make sure that all the sample going into the gas analyzer is also been filtered by the HMEF. Most other people are also using an exhalation HEPA type filter to make sure that the particles are not going out in the room. I put in some recommendations that are on the AARC website, which I've been a member for many, many years. And this is also based with the Society for Critical Care Medicine. I think a lot of these tie into what I've seen in Saudi, but just to remember, strict infectious disease, do not delay intubation. I think that's one of the things they have seen. People will sometimes try to do a normal type, less invasive, more invasive, and even more invasive if they need to. But the patients that are the sickest are usually getting sick very, very quickly. So some people are using a high flow nasal cannula to deliver oxygen, but they're having to watch the patient. And even the use of NIV is kind of controversial. Some people say yes, some people say no. But what they found is you really have to monitor the patient, because NIV, if anyone has ever worn it, is very uncomfortable, and the patient is going to be very combative at some points because they're going to be so sick. And they say if you're not successful in a short period of time, look for intubation. And then, of course, mechanical ventilation on their website follows the ARDSNet protocols, low tidal volumes for protective lung ventilation, mostly a assist control, either with pressure control or volume control. Plateau pressures, of course, less than 30, and low PEEP FiO2 table from ARDSNet. Now, sometimes they're saying when the patients are sicker, you may have to use higher PEEPs. Also, they said for the COPD patients, you may want to use more of a COPD protocol if they have a high compliance versus the low compliance that they're seeing on usually the sickest COVID patients. I did want to mention, especially if you've never used GE, that we have some clinical decision tools to help you individualize your ventilation. Most studies are showing that protective lung ventilation, proper PEEPs, proper tidal volumes are very important for less damage to the lungs. So with GE, we can do an FRC measurement. It's basically a modified nitrogen washout while it's on the patient to measure the amount of FRC and measure their static compliance so you can find the optimal PEEP. And of course, the highest FRC with the highest compliance is usually more of an optimal PEEP. If you want to do it for several levels, we can do a PEEP in view. We also have the ability to do spirodynamic curves. So you can look for the lower inflection to make sure you have enough PEEP, or an upper inflection point to make sure that you're not over distending the lungs for tidal volume breaths. And of course, we have a continuous indirect calorimetry for feeding your patients. Most patients are fed based on predictive tables or predictive equations. And most people consider the indirect calorimetry, continuous measurements, to be the gold standard, because not are you just guessing what the patient's, hold on, am I still sharing?
Yeah,
Sorry,
you're still.
okay, I had a flash, so sorry about that. So, but indirect calorimetry, measuring it continuously, this shows you the patient's actual caloric burning that they're doing. So you can feed them exactly. So you're not underfeeding, so they get fatigued because they don't have enough nutrition, or you're not overfeeding and you're producing metabolic CO2, which can also be harmful. One other tool that's on all of our RH60s is a spontaneous breathing trial. Everyone's doing spontaneous breathing trials. I've done them for years. Most of the studies I've read are showing that just a successful 30-minute spontaneous breathing trial is an excellent indicator for being able to discontinue mechanical ventilation. So GE has a unique tool with theirs, where not only do you start the spontaneous breathing trial with CPAP and pressure support if you want, but you can also have stop criteria besides apnea. So that way you can also set a time limit. So if you want to do a 30-minute trial, if you're not there at 30 minutes, you can come back, it's already done, and then you can look at the results. And the results are nice because they're all on one tab. It'll also calculate your RISB, and you can look at these minute by minute. So that way you can quantify your SBT results from test to test to make sure if the patient is getting better. So these are just some nice tools that I just wanted to remind people, or people that didn't know, that we do have these available on our GE RH60 and on the Ingstrom. My last slide I wanted to show you was our gehealthcare.com ICU resources webpage. All you need to do is go to gehealthcare.com. About the middle of the page, you're going to see a feature offerings. And on the right side, you can see it says ICU ventilation resources. And then we have all kinds of guides. We have even a training class for RH60s that has a certificate at the end. This is something that we usually charge for, but because of COVID and so many new users, we have offered this for free during the COVID crisis. So even if you're someone that has an RH60, it's a good tool for a refresher or any new employees that you have. We have lots of quick reference guides, user manuals, participant guides. We have lots of new videos that are very short, 3 or 4 minutes, to show you how to turn on the RH60, how to go through the screens, how to turn it off successfully, different things like that, even things on infection control, and a list of our ventilator supplies and accessories. And that's all I have.
Thank you, Mr. McCall, for this informative presentation. Thank you very much.
No, thank you for having me.
I just want to remind the audience that there will be a Q&A session at the end of the webinar. So if you have any question about any presentation or any question to the presenter or to the speakers, you can write it in the chat, and we will get to it at the end of the webinar, and we will hopefully answer all your questions. Our next speaker now is Mr. Mshari Rubian. Mr. Mshari Rubian has been an RRT for a registered respiratory therapist for more than 12 years. And he is now working as a clinical application specialist in Al Jil General Electric company. Mr. Mshari, please go ahead.
Well, thank you very much, Sultan, for the introduction, and thank you, Clay, for the first part. Let me just try to put the presentation over. Okay. Well, can you see the screen right now?
Yeah, the screen, yes. Now it's working.
Okay. Okay, thank you very much, everyone, for coming for attending this webinar. I will be mainly talking about how to take care of COVID patient in mechanical ventilation, and that would be according to the protocol made by the Ministry of Health. As you can see, this is the link to this document. This document has 7 pages, and it has all the information needed to manage the patient from oxygen therapy, high flow nasal cannula, non-invasive ventilation, till high frequency and last stage ECMO. Mainly, we're going to focus about the mechanical ventilation part, and we will try to see what kind of feature GE CareScape has to offer in order to perform a good lung protective strategy for the patient who suffer from COVID-19. Very important note, according to the MOH recommendation and guidelines, if you're going to use a non-invasive ventilation for your patient, it's preferable to use a negative pressure room. If that was something not possible, then a HEPA filter at the expiratory side should be placed, and this is according to the Saudi Center for Disease Prevention and Control. Well, the MOH has classified the COVID patient into 2 categories in terms of the ventilation strategy. So, as we can see here, there is phenotype L and type H. With type L, usually it's characterized by low elasticity and high compliance. And usually the way to know if the patient is type L or not is to assess the static compliance. If it's over 40%, then I mean, if it's above 40 centimeter of water, then most likely the patient have high compliance, and usually there is a different pathway, different ventilation management would be taking place. While with type H, when the compliance is below 40 centimeter of water, then we notice that lung is wet, and there is an issue of low compliance, so a different strategy will be implemented. There are 11 recommendations made by the MOH in regards to mechanical ventilation with COVID-19 patient. First point is to use volume control mode, which is a volume control strategy. Tidal volume should be maintained between 6 and 8 ml per kg. This is per predicted body weight. And we should limit the plateau to less than 30 centimeter of water. RR should be between 15 to 20, and we should allow for permissive hypercapnia. The initial setting for the beep should be between 5 and 10. Titration should be done up and down according to the response of the patient. Then we should target the following parameters, which is an SpO2 of 90 to 92. BO2 should be at 60. Arterial pH should be above 7.3. Just to clarify something, the BO2 of 60, it doesn't say to you that it should be above 60. It's about targeting the BO2 at 60 millimeter of mercury. That would help in, minimizing the FiO2 being given to the patient, thus minimizing oxygen toxicity. And number 4, as we can see, we have to assess the lung strain and recruitability. And since we are talking about this part, a nice thing about the GE CareScape is, as Clay mentioned, you would be able to measure the lung strain because you do have the functional residual capacity or end expiratory lung volume in a scientific definition. And you would be able to know exactly if you are recruiting the lung or not. if you are interested for more information, please Clay did share a nice resources from GE. You would find a lot of information in this regard. Number 5 is to assess the pneumonia phenotype. As we said, is the case phenotype L or phenotype H? That would depend on the static compliance, as we mentioned. And if you look at number 6, we noticed that the static compliance, if it's over 40, then we are dealing with L phenotype patient, and we should consider keeping the beep between 5 and 10. While if the compliance was below 40, then we are talking with about category or type H, and beep titration should be done according to the beep FIO2 table, and recruitment maneuver should be done. But we need to put in mind that the MOH does not recommend to exceed beep of 20. For sure, if we are looking at number 8 now, neuromuscular blocker agent, yeah, it should be used as intermittent boluses and given for the first 48 hours. If the BF ratio was below 150 and according to the ARDS protocol to facilitate a protective lung strategy. Well, here, daily sedation, vacation, and assessment of sedation requirement and the depth as per Richmond scale. Braun is recommended for patient with refractory hypoxemia. It should be done for 16 hours. If still the patient was having refractory hypoxemia with extreme settings, then doctors might consider ECMO for that patient. And those are basically the 11 points. Here, as we can see, this is the made by the MOH. It's a guide or a roadmap of how to manage ARDS patient. I'm not going to go over this table, but just to show you, it is very good for hospitals who doesn't have like a clear protocol for COVID-19. They could follow the MOH even if they were not in the same region. And basically, if you look at this roadmap, it takes the patient from the point of requiring high oxygen and the needs of intubation, then what you should do exactly in terms of the RR and the SpO2. And if you look down there, you will see that it can run down to performing a prone position to the patient and ends with the ECMO intervention at the end, as you can see. Well, thank you very much, guys, and I hope this presentation was beneficial, and I'm gonna now handle the mic to Mr. Sultan.
Thank you, Mr. Mshari. Thank you very much for your presentation. It's really informative, and the guidelines are clear for the users. And the thanks goes to the MOH for clearing the path for us. Our next presenter is Mr. Firas Al-Mahdi. Mr. Firas Al-Mahdi is one of the, I personally speaking and from personal experience, he is one of the guys who I cannot thank enough for standing with us during all this time of crisis. I personally called Mr. Firas at middle of the night, early in the morning, in the afternoon, in weekends, in weekdays, about stuff and parts that we are missing. And he will bring it to us in day and night and evening and morning, weekdays and weekends. So I cannot really thank him enough. Mr. Firas is working for, Mr. Firas Al-Mahdi is working for Draeger company as a supervisor biomedical engineer. He's been supervisor engineer for more than 10 years, since 2008. And I'm really glad to have you, Mr. Firas. The mic is yours, and thank you very much for being a speaker with us.
Assalamu alaikum. Hello, everyone. I would like starting for thanks for all people attendance for this webinar. Second biggest thanks I giving to Saudi German Hospital to make it that one. And as you know, that Draeger and Saudi German have cooperations before more than 20 years. And a special thanks for Mr. Sultan to invite me to share some knowledge for the ventilators and accessory we can use it. First, I will give a brief about the Draeger, abstract word of COVID-19, and preparation of ventilation and accessory recommended should be using with COVID-19 patients, auto-star autotherapy, high flow, and Seattle BAB Plus. First, I will introduce myself. My name is Firas Al-Mahdi. I was born in Damascus. I was a graduate from Jordan University Science and Technology, 2007, and as biomedical engineer. And 2016, I take MBA master degree from Geneva Business School. I joined Draeger first time 2008 as a biomedical engineer first service, and I shifted to sales 2014, and now I am supervisor for Western regions for sales. I'm talking about Draeger. Draeger is manufacturing medical and safety technology product, is doing product support and saving of lives around world hospitals, also the industrial emergency service and meaning all industrial. The founded Draeger in Lübeck near to Hamburg in 1998, has one growing worldwide listed. It is a fifth generation family business and has more than 40,005 people worldwide presented, and now 190 countries around the global Draeger. Nowadays, with the global spread concern also for Draeger, our aim the Draeger that responsibility supports the hospital and people, COVID-19 and safe equipment facing global challenge. As you know now, have problem for COVID-19, Draeger open one pages. You can sharing the knowledge if you want. If you need any instruction, any question, you can go to the web directly. I showing that. This only for COVID-19. You show that page. You have all ventilators and accessory monitoring and anesthesia. You have some video you can learning and some instruction for use. You can use it. If you need any more question, you can directly asking. This only opening when you starting Corona in the worldwide. Now we're starting for what is COVID-19. All you know, the COVID-19 is a virus. What is the virus? A virus is a microscope game that causes disease such as a cold and flu. Virus needed living host, personal or animal or plants, and grow repact. One inside host cells virus release is in DNA or RNA. This virus host called to make copies itself. This virus copies are released from cells to infect another cells causing. COVID-19 is coronavirus disease. It is a respiratory infection caused by new type 4 coronavirus. It is started in 2019. This affect of airway or lung and contagious spreading easily from personal to personal. COVID-19 is called novel, and the official name of this coronavirus is SARS-CoV-2. The coronavirus shaped like ball, and you have specs. Are you writing? Now you see the numbers for the world around 8,600,000 and in KSA 145,000. But alhamdulillah, in Saudi Arabia, you have recovery in percentage is good, around 65. Preparation ventilation. The main goals for preparation ventilation be used before to using the ventilator minimize connecting between the patient and the ventilation in the same time. What the step you can follow that one? One, you should make completely self-tests before putting any machine beside the patient's beds. Two, keep it all the power cables and also oxygen and air hose connected. Three, put it all accessory and one set, disposable expiration, filter, circuit, flow sensor in one set, and don't open before admission to patients. Fourth one, keep a minimum 1.5 meter distance between ventilator and beds. Five, make tests of leakage before admission to patients. Now, you should be one machines inside behind the patient, and we will trying to one RT should be touch the patient and sitting for the ventilators. We can go to simulations. Now I showing simulations. For Draegers. This simulation, you can go to simulations 1. And start simulation, start. Now we'll start for the ventilations. This switch it on, this real ventilator, and press confirm. We go to here, standby, and press standby, and press rotary knob to confirmations, press alarm silence, and go to system checkup, go to breathing system, and will start. When you will start, you press rotary knob and press confirm. Leakage to will make it, and we giving the readings for that one and everything. And when you start for leakage breathing, you see this page. You should be sealing the resistance, the circuit. After that, we were reading should be leakage less than 300. We will back to presentations. As you know, you have 3 types for circuit: 1 limb and 2 limb, and heated circuit dual and single. 1 limb you can coming with expiration valve or without expiration valve with the flow sensor also. 2 limb is normal circuits. Dual heated circuit is coming for inspiration and expirations. Inspiration and expiration heater wires inside the 2 limbs. Filter. Filter can protect patient according to hospital guideline and abhorrent bacteria that led cross compensation on the filters, device and the patients. We have 3 types in Draeger filter. Filter alone with variables, HME, filter with HME. Now we have 2 types for filters. We will talking for mechanical and electric filter. What the difference between? The first one, mechanical, is high hydrophobics and optimal filtrations and high resistance and higher dead space. But electrostatics is giving good filtration but lower resistance. Heated and ministry available of mechanical electrostatical without bacteria filtrations. How you know this filter we can using depending for practical size. Example here, the electrostatical is between 0.4 until 0.8 micrometers. Mechanical between 0.2. As you know, the ICU ventilator may be working with humidifier or without, active or passive. If we active the humidifier, no need put it any filter with YBs and put it only filter on the expiration. this filter is HEPA filter. And when passive humidifications, you should be put it twin filter. This is HEPA and HME, and also put it HEPA filter in expiration valve. Type of expiration. We have two types for expiration, reusable one and disposable one. Reusable one is coming autoclavable. You can send it to steam 134. You can steam it. Disposable one, you can use it for single patients. This is recommended for setting and replacement. This recommended depending for Draeger's, the breathing system filter not access to 24 hours, change after every patient, but this depending for guidelines for every hospital. Expiration valve not exceed 7 days, change after every patient. Now we will talking for some auto starring accessories. We giving oxygenations, tracheostomy, and oxygen nasal, and oxygen mask, and also Venturi mask. We will talking for some procedure we will using with patient COVID-19 is high flow therapy. High flow can be effective by use treat patients with moderate level hypoxic respiratory failures. This wave for recovery and when you show the patient is faster. We have two ways to can connect it high flow nasal cannula. First one with oxymixer, oxygen and air blenders, and with ventilator of Draeger directly. Example, Evita series, Evita 300, Evita 500, Evita XL, and Savina. Now, I will open the video regarding for high flow, how can you connect it?
In the following, we present our heated inspiratory breathing circuit for high flow therapy, the high flow star system, and the associated high flow star nasal cannula for adult patients. The high flow star system is a heated inspiratory disposable breathing circuit system that can be used to carry out high flow therapy. The breathing circuit system is suitable for use during O2 therapy using ventilators such as the Evita family and the Savina 300 family. In addition, the breathing circuit system can also be used with a blender, such as the oxymixer from the Draeger portfolio. The high flow star system is also intended for connection to a humidifier and supplies patients with heated, humidified breathing gas with an increased oxygen concentration. The embedded heating wire helps ensure even heat distribution, which provides optimally climatized air for patients and prevents condensation. To begin with, we will show you a step-by-step guide to attaching the high flow star system to the oxymixer blender from the
screen is jammed.
Now it's okay.
Draeger portfolio. First, take the water chamber and push it into the humidifier until it clicks into place. Take the water supply from the mounting on the water chamber and connect it to a sterile water source. Ensure that the water flows into the deaeration chamber and that the sealing cap is open. The water chamber is filled automatically by means of the auto feed mechanism, and a float gauge ensures that the water level remains constant. The first time the water chamber is filled, be sure not to go beyond the maximum water level mark. Next, take the O2 hose from the blender kit, which is used to connect the oxymixer to the water chamber. Connect the hose to the oxymixer. Remove the sealing cap of the humidifier chamber and connect the other end of the hose. Now take the heated inspiratory hose and connect the connector at the end of the hose to the second opening on the humidifier chamber. In addition, the temperature sensors and the connector for the inspiratory hose heater must be connected to the humidifier and the hose system. The breathing circuit system is now fully connected. Please note that when connecting to a gas blender, the short blue inspiratory hose is not needed. If you are using a 22mm adapter on the blender, use the short blue inspiratory heated breathing circuit and connect it to the blender and the water chamber. The breathing circuit system is now fully connected.
Yes. I will back my presentations. Yes. And also, if you can need it connected for ventilator the same way, but we should be connecting small blue tubing with ventilator. Now we will talking about advantage for high flow. Is the high flow can be efficiency delivery more oxygenated and recovery faster than non-invasive respiratory therapy. High flow can be do more than just auto solution levels, and the relief can improve mucus clearance and increase tidal volume and end expiration in lungs. High flow more comfortable because you can swivel and you can movable for the patient, not make it any allergy for the faces, and improve both patient tolerance and therapeutic efficiency. Heated hose used avoid damage for lung, airway, and ventilation patient dry cooling breathing gas. This risk for infection reduce. Now we will talking for Seattle positive airway pressure. Seattle coming this for university. What you do this study for bubble CPAP, this general name. As you know, all the bubble CPAP is all the therapy using for neonatals. That one is innovation which use proven advantage bubble therapies, such associating effective similar high frequency ventilation combined with a unique design. It helps infant respiratory breathe easier. This circuit for bubble CPAP or Seattle CPAP for Draeger name solution. This challenge coming worldwide, almost 1 million infants die each from the respiratory disease. Respiratory muscles excitation is a major causes of failure in conventional in a number of bubble CPAP therapy. This failure which occur in health baby receiving in therapy, often in the endotracheal tube and mechanical ventilation that carry the risk of the tissue damage and inflammation. Now, we will talking for advantage for that Draeger Seattle BAB Plus. This Seattle BAB Plus bubble CPAP system is designed to create continuous positive airway pressure and pressure associations. And the angle for Draeger, especially 135, this degrees what you benefit that one. The sub-measured tubing increase amplitude association, thus providing effect similar to high frequency association and ventilation for improving exchange and offer more efficiency respiratory. This association throwing listen to work require from the respiratory muscles. Seattle BAB advantage safe and effective, easy to use and easy to set up. It was designed to promote infant safety and unique design modified with pressure refilled valve, lock safety. You can see in the humidifier tanks with one, and avoid united beep level. Provide comfortable option for CPAP support to infant baby flow plus interface, including frenulum feeding tube, which minimizes blinks. Prevent unnecessary disconnection and the pressure loss through swivel connecting. Prevent unwanted pressure spikes. Now we will show the completely solution for bubble CPAP is coming circuit and humidifier chamber and tank. This completely circuits and oxomixer, oxygen and air, and Baby Flow Plus. Baby Flow Plus is contain three things. One is baby flow and mask or bronch and headgear or cap. Thank you for attention. If you need more information, you can contact with me. This my numbers and my email. Mr. Sultan.
Thank you very much, Mr. Faras.
Thank you.
Really thank you for your presentation. Right now we will have our Q&A session. But before that, if I can just summarize a quick recommendation from my experience during this crisis time. You know, it's during crisis time, you always work with what you have. This is an absolute rule you have to go by. But if you have the luxury and the privilege of having whatever you need to work perfectly with the COVID-19 patients, you'll be very, very lucky. But as a general rule of thumb, as they say, for my fellow RT and for my fellow nurses who are working directly with patients, always try to avoid ambu bagging the patients unless you really have to. If your ambu bagging is not the keeping patients alive, don't ambu bag a COVID-19 patient. Intubation has to be done very quickly. The last thing you want is to have a COVID-19 positive patient with an open airway to the atmosphere. That's why it's always recommended to use a glycoscope for the intubation. Always try to use disposable circuits. Always use HEPA filters. Try to use disposable exhalation valves. Always have an inline suction catheters connected to the patient circuits and AT tube. Avoid opening the circuits for any reason, unless you are really like saving patients' life. Try to not to open the circuits. Keep the circuits closed from the patients to the ventilator. Try to avoid having the nebulized COVID-19 viruses in the patient's atmosphere. Take care of the patient's airway. Have a very well airway maintenance. Trying to avoid a blockage of the ET tube or any problem to the ET tube, because if that happens, you will have to open the circuits. You will have to go through all the danger of the intubation again. And also at the end, it's always not recommended, but you have to take care of yourself as much as you are trying to take care of the patient. So try to make sure always to follow the guidelines, protect yourself, wear proper PPE, protect yourself from the exposure to the COVID-19 positive, because, you know, in our hospital and in every hospital who has COVID-19 positive, losing a staff for exposure is something it's not recommended, and it's not welcomed actually, because we don't want to lose a staff for exposure. We're trying to keep our staff always safe. So the hospital provide all type of PPE needed for the RT to keep themselves safe, and for the nurses, and the nurses and all healthcare provider have to apply by the PPE rule. We will go now to the Q&A session, and our colleagues in Saudi German organizing team, they have arranged some of the got some of the questions from the chat. The first question was how to make a safe intubation as regard to spread of infection. From my personal experience, there is no ultimate way to keep the intubation safe, but there are ways to minimize the risks. First of all, the intubation has to be done by a very skillful person. We're trying not to miss the intubation from the first trial. Second thing, during the intubation, the RT or the nurse or the doctor are not supposed to ambubag the patient. We try to do intubation without ambubagging the patient. The third thing, the new thing that's come up with that came up with the COVID-19 period is something that people invented, something we call intubation box, which is a box that's made of transparent plastic. It will allow you as an intubator or as an RT or as a nurse or as a doctor to see and to visualize the patient's body and face, and in the same time to deal with the patients from
You are muted, Sultan.
type from the beginning.
No, it's just the last 2 seconds. But
Okay. So the third thing that people came up with during this crisis time is what we call an intubation box, which is a transparent plastic box that's made of plastic that will help the healthcare provider to see the patients during intubation and deal with the patients, and at the same time have a barrier between the patient's breathing and the healthcare provider. Those are like three recommendations for safe intubation. As we mentioned, try to do the intubation as quickly as you can. Try not to miss the first trial of intubation. Try to avoid ambubagging the patient. And in the same time, if you have an intubation box available at your hospital or at your institute, it's always recommended to use it. On top of all that, you should follow the standard procedure of personal protective equipment for COVID-19 positive patients. I hope this answered this question.
Mr. Sultan?
Yes.
Yes, this is Clay. I just wanted to ask you this question. So hold on one second. So whenever you're intubating, or if you had to use the ambu bag, wouldn't it be good practice to always make sure that the HMEF is on the end of the circuit, just to protect anything coming from the open tube whenever the tube is open, even during intubation?
Yes, it's true. HEPA filter is like a recommended for usage for all COVID-19 positive patients. And in our clinical experience, we connect the HEPA filters to the ambu bags before bagging to the patients. We put it between the ambu bag and the mask, or between the ambu bag and the ET tube, trying to avoid the risk of having the virus spreading all over the room. But it's still, even with using the HEPA filter, it's always recommended, because without the patient's intubation, having a tube in his throat, there will be a lot of leakage around the mask. And this is where the danger came from. The viruses will be spread from the leakage around the mask. When the patient is intubated and the cuff is inflated, this will minimize the risk of having the virus spreading all over the patient's atmosphere because of the leaks of the patient's mask. Mr. Clay?
Yes.
There is a question for, and it was asked in the chat room, which is, what is the recommendation for cleaning the gas sampling lines for COVID-19 patients?
Well, there's two different ways to look at this. So if you are using an effective HMEF for viral and bacterial, most of those will have a sample port. So if you connect the sample line to the port on that HMEF, then the HMEF is going to filter that sample line before it goes to the gas module. But also built into our gas modules for the Defend water trap is also filtration, and it's filtering at 99.9997, I think, for viral and bacterial. So that would be, if you're using this on a COVID patient, you would probably want to dispose of that after that patient is off the ventilator successfully, and just make it a single patient use. But other than that, everything is being filtered that's coming from the sample line, at least by the Defend. But in most cases, you still get your best filtration for everything by having an effective HMEF.
Thank you very much, Mr. Clay. And
Quite welcome.
there is another, there is another question: how to make safe intubation. I think we answered that already. Do we have the link of COVID algorithm, please? If you, for the person who asked this question, if you do mean the recommendation of MOH, that was presented by Mr. Mishari, I think this is available on the MOH website, right? Isn't that right, Mr. Mishari?
Yes, it's right, and I did post the link to that question, so they should be okay.
Okay, thank you very much, Mr. There is a question here that in COVID positive patients, can we apply both non-rebreather mask 15 liters per minute with 4 liters per minute nasal cannula? Is it effective? I really don't see any need for that, because when you give a patient a 15 liter per minute non-rebreather mask with a good seal, you are actually providing him with around 100% of oxygen, from like 80 and above % of oxygen. I don't know why would the patient still needs 4 liter nasal cannula. I've never experienced using two different oxygen devices for the same patients. I don't know if this will be effective or not. I really cannot answer that. Does any of the speakers have answer for this question?
I can voice some experience from a long time ago that we used to do this or attempt to do it. But as you said, if you have a true non-rebreather system and you have the flows high enough, because it's not designed to be a partial rebreather, it should be 90+% oxygen. So if the patient is not oxygenating with that, with a high enough flow, and as long as the bag is not completely deflating, you have a high enough flow. But if they're not oxygenating on that, then they're going to need some extra intervention. I mean, adding more flow is not going to help them. You know, having a good seal on the non-rebreather and it working as it's intended to is the best type of therapy. So really, it's just a waste that I've seen. I've never seen any benefit from it.
Thank you, Mr. Clay. And I think this question for Mr. Mishari and Mr. Clay: how the GE machine will find an optimal PEEP for COVID-19 patients?
What again?
Sorry?
How can the GE mechanical ventilator, does it have the option to determine the optimal PEEP for patients based on the patient's monitoring the readings?
Yeah, definitely. So with GE ventilators, you do have the option to measure the optimal PEEP in a different ways. Some ways are better than the others, but it's totally about the availability and whether you do have the full version with the gas module or not. So if we are using the gas module, you would be able to know exactly where is the optimal PEEP that patients need, and this is due to the fact that using the technology of functional residual capacity will measure the amount of volume at the end of expiration. So this way you would be able to know exactly if you have opened the alveoli, and you could compare the test with a different attempt, and you could compare the recruitability or the gain of volume you opened in the alveoli. So definitely it's good to use the FRC and the beep in view feature to define your optimal beep. Other ways to define the optimal beep for those who doesn't have the FRC function is through the loops. Basically, there is a tool been provided by GE to all, even the basic or the standard GE CareScape R860, and that would be the loop measurements. So basically, you would be able to assess the lower inflection point and upper inflection point, as Clay did mention in his part, where you could look at the lower inflection point and see the change in the pressure compared to the change in the volume, and you could minus the B2 minus B1 divided by volume 2 minus volume 1, and then you could get the compliance at that stage, and you could decide whether to go with the higher beep or lower beep. So definitely you do have the option in the GE CareScape, but if you have the full feature, then you would have more information, more reliable data.
And Mashari, I'd like to add something to that. A couple of things. For one, we have some customers that ask us if you can do transpulmonary pressures. So actually we have a port on the front of the ventilator that's called a POX. And we have many of our customers that will hook that up to an esophageal catheter and make esophageal measurements. And then they'll subtract the PEEP, and then they get the transpulmonary pressure. So it's actually very easy to do if they want to do that. I'll also have customers say, when's the best time to do an FRC? So I tell them, think of it like the patient is coming in. You don't know what their functional residual capacity is on their initial ventilator setting. Just like you do an initial blood gas, initial lab work. A lot of people will get an initial FRC with the compliance and use that for a baseline to see if what you're doing through the course of care is making the compliance and the FRC better, or if it's making it worse. And then you can use our PEEP in view to actually do PEEP studies, test it up to 5 different levels of PEEP. And then you can see which one has the greatest FRC with the greatest compliance, because you can increase your FRC, but if your compliance starts decreasing, then you're over distending. So both numbers have been shown in many studies to be the most important for trying to set optimal PEEP. But we give you several different ways to look at that, including the spirodynamics, which is actually making pressure measurements inside the lungs, and it takes out all of the circuit compliance that you get, which is why you get the loops with the flexibility.
Yeah, I'm glad, Clay, you mentioned the esophageal balloon and how it's very beneficial to define the optimal beep and the proper tidal volume. And I would also add, since this is a great opportunity to say, using esophageal balloon is very good for a patient who has abdominal compression, or I would say if they are obese, because usually those pressure tends to push upward to the lung and cause the lung to get collapse. So it's very important tool in case of obese patient that will definitely help you to set the optimal beep for obese patient or patient who have an issue of volume restriction, basically.
Thank you very much, Mr. Mashari and Mr. Clay. I think there is a question here, and I think Mr. Firas can answer this. Is the flow sensor, I don't know if the question was written right, is the flow sensor single use is compatible with MRI, and do we have it now in the kingdom?
The flow sensor don't have any material irons you can effective for MRI. You can using the same what you're using for normal one. Okay, so all flow sensors are MRI compatible. MRI compatible because don't have any iron to can distributing for MRI. But if you need single use, you have single use and you have autoclavable for sensor. You have 2 types.
Okay. Mr. Faras, can you advise us, or Mr. Clay or Mr. Mshari, whoever has an answer for this, on how to clean a laryngoscope that is used during intubation? From my personal experience, we clean it with water and soup, and we sink it in Sidex.
Right, that's one.
Yeah, exactly. Then you do the leak test, then send it to ISD.
So,
No, we're talking about the blades of the laryngoscope, Mr. Mshari.
Oh, you're talking about, okay.
The blades of laryngoscope. I don't know if our practice is right. We actually clean it with soup and water, and we clean it with we sink it in the Sidex for 24 hours.
yes.
So when we used to do it, we used to use like a test tube brush, and that way you could scrape it. So if there's any very thick secretions, it would come loose with the soap and water, and then of course we would sterilize it. If it's an older one, which I don't know if there's any of them out there anymore, we would also check the bulb to make sure that it was nice and tight when it went on there, and check the batteries to make sure that it's all ready for use. And then of course have extra batteries and extra blades with extra bulbs if needed for the kit once you restock it.
Okay, and there is a nice question that is always been asked, like since the beginning of this crisis. For non-intubated patients who need some sort of support, what do you guys recommend of using? Is non-invasive better, or is high flow nasal cannula better, and why?
GE does not have. Go ahead.
Sorry. Go ahead.
No, GE does not have a recommendation, but I've been following this very closely. Of course, I'm from the U.S., so I've been seeing how they do things in U.S. and Europe, over here in the Middle East, in China, all the different places. Initially, high flow was frowned upon because it could be easier to spread particles. So they were recommending nasal CPAP because it's more of a sealed system. But as this has gone on, and as I've seen different studies, people are going back to high flow and just trying to keep the contaminated areas as clean as possible, just because they feel like for one, it's more comfortable for the patient. So the patients a lot of times will do the therapy better because it's much more comfortable. But as I said in my other, and from the Society of Critical Care Medicine, they say you have to watch the patient closely. And if they're not responding within the first 2 hours, most people are going for intubation. They're not going to step up to a BiPAP or a CPAP device from a high flow. They're going to go straight to intubation because they know the patient is getting very sick. But that's just the things that I have read in most of the articles.
Mr. Faras, anything to add?
No, only I can to taking sequence for the patients. You starting for high flow. After that, if you not, you can go to for non-invasive mask for CPAP or BiPAP. After that, you go to intubation. This is a procedure you can using for that patients.
And if I can add from clinical experience,
yes.
Most of the hospitals will have their decision driven by the equipments that they have. For some hospitals, they're using the same ventilators as non-invasive machines because of ventilators that have non-invasive capabilities. Those hospitals, or the RTs in those hospitals, they don't like to use BiPAP over high flow nasal cannula because that will reserve a potential ventilator from a patient who might need it in this time of crisis. So it's always preferable to use high flow nasal cannula and save this mechanical ventilator for a patient who might need it in this time of crisis. And because of high flow nasal cannula proving benefits, it's always recommended, even if you want to use a high flow nasal, you can use high flow nasal cannula on a COVID-19 positive patients, but you have to make sure that you install enough HEPA filters in the room and keep the air circulation clean as much as you can. And I hope this answered the questions. Anything to add, Mr. Mshari?
I do have one point. There is in Italy and France, some of our clients there, they've been using the helmet as an invasive ventilation, and due to the fact that GE ventilator has the ability to increase the voice flow to 20 liter per minute, which is the expiratory continuous flow. It helps a lot in removing the CO2 inside the helmet. We know the helmet of non-invasive ventilation was exists long time ago, and we didn't see it really common in the practice. But nowadays, since they developed, like, I don't want to name certain companies, but like for example, National Guard Hospital, they've been using this helmet, which is very light film, and it's there is a plastic materials that goes around the neck, and it's sealed. There is no tightness, and I've been hearing from a lot of artisan physicians there that it makes a lot of benefits to the patient, basically. And what I would like to add is you could also use it with the CareScape ventilator due to the fact that it could wash out that accumulation of CO2 inside the oxygen. Thank you.
Okay, there are still two questions remain. Question says, if you are exposed to a positive COVID-19 patient for 1 day and you did the test directly, is the results accurate if it comes negative? Let me say that dealing with a positive COVID-19 patient doesn't mean that you're going to catch the virus. It always depends on how much careful you were and how much you were following the PPE recommendations. But still, a test on the same day, I think if it's positive, and then if it's in your body, it should show positive. I don't know, but still, the test has some margin errors, very minimal margin error. So I don't think you should be you should have like fear or something if you were exposed to a positive 19 patients. If you are directly in contact with the patient, you should get tested. And if you were not in directly contact, especially or if you were not wearing the enough PPE, you should also be tested. But you shouldn't have to be afraid. I mean, like, there are a lot of talking now about the psychological effects of having the coronavirus all around the place, but you should have trust in God, and you should watch yourself for symptoms, and you should be careful when you're dealing with patients of COVID-19 and follow the recommended personal protective equipment. The last question says, is it safe to suction the nose? That depends if the patient is intubated or not. If the patient is not intubated, suctioning the nose should be minimized, because suctioning the nose will stimulate the patient to cough. And we don't actually want the patients to cough, especially if you are not ready for him to cough. The second thing, if the patient is intubated, actually if the patient is intubated and the balloon cuff is inflated, that should make the proper seal. And if you're suctioning the nose, there should be no problem of having the virus exposed to the room, because the patient is breathing through the closed system of the ET tube and the ventilator. I think it will be okay to suction the nose, but we still go back to the basics of dealing with COVID-19 positive patients, which is wearing the proper personal protective equipment and having this patient in a HEPA filtration or negative pressure room, which will minimize the risk to the very minimum. Thank you very much for all the audience who've attended. Thank you very much for all the speakers who joined us and gave us from their precious time and their precious knowledge and experience. Thanks to Saudi German Hospital organizing team, Mr. Mahbub, Ms. Heidi, Mr. Islam, our IT engineer who made this possible. Thank you very much. We're really glad to have you, and it was a very wonderful time to be with you here in this informative webinar. Thank you for the speakers, and if you have any last words you want to say to the audience, Mr. Speakers, Mr. Mshari, Mr. Clay, and Mr. Faraz, please go ahead.
Well, I do have just one point to mention. I would like to thank you, Sultan, for inviting us as Al-Jil and GE company. We do really appreciate this invitation, and it's an honor for us to be with you and with all of these participants from all over the world. Thank you.
Mr. Clay.
Yes, I would have to say a big 2 thumbs up for you and for all those that have put this together. I think it's excellent. There was a lot of webinars that started out when COVID was new, and I think they're getting fewer and far between, but I think there's still good information, and we're still learning new things every day. So just as you said, you know, you're going to use whatever equipment you have. We just want to make sure from Al-Jil and GE that you have all the resources that you need to use our GE equipment as thoroughly and as comfortably and as completely as possible. And just thank you again for all the care that you did for these patients. I felt bad not being in the hospital on the front lines with all of this, because I've done that for over 30 years. But making sure that our customers that we cannot see face to face, trying to give them some online tools. I do stress the gehealthcare.com ICU resources page. Lots of information when you get time. And there's also a Ventilator Alliance app that Draeger, GE, most all of the manufacturers have put together some information that you can have on your phone. And it's a really good quick access tool. But thank you again for having me. And please stay safe and stay well.
Thank you very much, Mr. Clay. Mr. Firas.
Thank you for all. Thank you for Saudi German Hospital regarding for these invitations. And Mr. Sultan, really thank you for you to invite to me that one webinar. Thank you. If you want any question or any information, you can contact direct with Draeger information. Or if you need personality, I can answering directly. Thank you for all.
Thank you very much, Mr. Firas. Thank you very much, Mr. Speakers, Mr. Mshari, Mr. Clay. Thank you very much.